Important
Thank you.
paper, madam. Thank you. Can we go again with the next lecture, madam?
Yes, please.
I want to introduce Dr. Arulmozhi. He's a friend of mine. I know him for a long time. From Bilroth Hospital, we make rounds together. And he's a senior consultant pediatric neurologist, consultant neurologist at MGM Group of Hospital. And I'm very privileged to introduce him as a second speaker. He'll be talking on epilepsy and driving. So, Dr. Arulmozhi, on epilepsy and driving. Yes, sir.
Morning, sir. I hope I
Good
am audible.
Yes, sir. You're audible.
Thanks a lot, sir, for that nice introduction. Now, 1 second, sir. Now, frankly speaking, honestly, in fact, if you had asked me this question 2 weeks before you gave me the topic, is there any role for a neurologist? Personally, I would have said I am not dealing much into this. But when I started reading into the literature, I found so much of new things, interesting things, which I thought is very, very important to my practical practice and for the health of the patients who are epileptic as well as for the community, which I thought I will happily share you with now. So as you said clearly, sir, epilepsy and driving is a social issue. It gives social independence to a patient who is suffering from epilepsy and improves the quality of life. For many people, it can be a livelihood itself. Without travel, the job is going to be compromised. And this peace of mind and travel, everything is going to be compromised. But at the same time, we have to balance this issue with the safety aspect of the society. Who is going to allow a patient who's suffering from epilepsy to drive? Luckily, this option is not given right now in our country to the hands of the neurologist. But when we look into the safety aspect of epilepsy in driving, there's a lot of literature, but there is a dearth of literature in Indian studies, which I'll be discussing to you right now. So this aspect is often overlooked. But another important issue which I learned is that looking into the aspect of driving in epilepsy, we'll have a better understanding of epilepsy per se. So the neurology of driving is the aspect or the requisite is a safe and a risk-free driving. So driving should be a risk-taking behavior which is strategically safe. The requisite is to receive multiple simultaneous sensory information, process the information, and judge the correct action and take it in the timely and accurate time and give a proper response. So this is the road to safety. So the neurological substrates of driving are, first is, as we know, is the perception of stimulus, the primary sensory cortex, the sensory inputs, which is lead on to the primary and secondary sensory cortexes, which requires a proper attention. Formulation of the plan based on the particular driving situation and relevant previous experience, which involves memory and judgment. And execution of action, the controls of the either a two-wheeler or the four-wheeler, which includes the accelerator, brake, or a steering. And monitoring the outcome of the above behavior for making corrective ongoing actions. So this requires proper insight. And most of the studies have used the word metacognition. The best outcome will be in a patient who is having a good cognition, whether he will be able to drive safely on the road. So this is called metacognition. So the Indian scenario, there are very few studies studying the safety or the impact of epilepsy on driving on an individual basis. There's only one Indian study from North India by Gangadeep Singh, who has picked up the strong negative impact on epilepsy on educational achievement, employment, marriage, and driving. But barring that, there's a lot of a huge knowledge gap on what, if you ask me, what is the actual risk of accidents contributed by epilepsy, or comparison of this risk to other medical conditions, contribution of various individual seizure types and syndromes to the individual epilepsy risk, and whether there is any role of EEG in finding out the driving fitness, and whether the crash is contributed by the AED, we do not have the answers in Indian studies. Now, this is a very good foreign study evaluating the relative risk of various medical conditions, including the age, on the impact of road traffic accidents. Here they say, interestingly, The neurological disease contribute to 1.75. That is, the relative risk is 1.75. The one, if you take the normal individual, the risk is 1. The relative risk is little bit only more than the normal individual. There are some other studies which say that there is no actual risk, extra risk contributed by epilepsy. Some studies, the risk is twice for the road traffic accidents. So there is actually a conflict in finding out the relative risk in various studies on finding out the contribution of crashes or road traffic accidents by epilepsy. But interestingly, if we compare this relative risk by other disorders like mental disorders or alcoholism, we have the clear data that it is definitely more dangerous or more contributing to the risk of crashes. 2 times more risk. Drugs and medication 1.5, and young drivers, just the age itself is a risk factor. Between 16 and 19 who are having high speeding tendency have 7 times more risk than a middle-aged person who is not having epilepsy, and aged more than 75 without having any other comorbidities has 3.2 times more relative risk of having a road traffic crash. Now, this is a Western study from Australia in the state of Victoria. Now, Victoria is a state having 2 lakh square kilometers in size with a population of 6 million. Somewhat the total combination of Tamil Nadu, Kerala, and Andhra. They have a very good road traffic data directory on the crashes. There is one good study here done by this author who has compared the seizure-related crashes and non-seizure-related crashes happening in that country, in that state. Now, he has the total number of crashes he has evaluated is 71, which is attributed to seizure-related crashes. And interestingly, the number of drivers were only 62, which means that these patients who had crashed got the license again, drove again, and again crashed. So the number of crashes are more than the number of patients. This is an interesting number. And he has compared it with the other usual routine crashes happening in Australia. And most of these studies are done on car crashes. So he has coined the term car crash semiology. I found it very, very interesting. We know about ictal semiology. We are talking about seizure semiology. This doctor has talked about car crash semiology. Based on the type of collision, he was able to discuss whether there's any difference from a collision from a non-epileptic crash and an epileptic crash. So the breakup he has given was that most of the people who are diagnosed with epilepsy were having complex partial seizures. A small portion contributed by absent seizures and generalized tonic-clonic seizures, but a larger proportion where the diagnosis could not be made on the type of seizure. So the interesting finding he has revealed is that people who had a seizure-related crash had an off-path veering. They were not able to maintain the lane. The lane discipline was very poor, resulting in a crash. So off-path veering resulting in a crash. Whereas in the non-seizure related crash, it was a straight collision hitting on a fixed object like a tree or a wall. The fatalities were almost similar. It was not significantly statistically significant between the two groups. So these statistically significant observations were most of the seizure-related crashes were single vehicle, where the epileptic patient was the sole occupant, and less likely to happen in the junctions or where there is a stopping. And as I said, there was an off-path veering and a collision with a fixed object rather than another moving vehicle. And he tried to compare the different types of seizures, like for example, idiopathic generalized epilepsy having a crash and a partial seizure having a secondary generalization, or a complex partial seizure having a crash. The findings were the people who had idiopathic generalized epilepsy and had a crash were always younger. The accidents happened more in the morning hours and with the fixed object collision, and they were also having other seizure provoking features like sleep deprivation or a missed dose or a drug use, concomitant drug use. So these findings may be already known to us. For many people, we know that the idiopathic generalized epilepsy happened more in the morning hours and having this age group. So this basic science or scientific information can be useful in counseling against people who are driving in this particular group of people who are having epilepsy. So another interesting study is the incidence of whether EEG is useful in finding out whether these people are safe, where we can allow these people to drive. This is a very fantastic study wherein the authors have found out the role of transient cognitive impairment in people who are having epileptic discharges. In epileptic patients who are having epileptic discharges, they wanted to know the real risk of driving in the real road. So they used an instrumented dual control car on road, and they drove 140 kilometers on the road with a 16-channel portable EEG and onboard computer. And the driving behavior was was noted every 3 minutes by a computer attached to a car. So with this data, they were able to find out that whenever there is a subclinical epileptic discharge, there was a poor lane keeping, but it did not lead to a road traffic accident. So these are all real tough studies, which involve a lot of dedications. The another new studies were based on video game simulation studies, where like driving a car. These studies have picked up subclinical seizures. During that time, the behavioral changes was not seen. As we said, we know it is a subclinical seizure. There is no physical change, but there was no collision. This is a video game simulation. During that time, no steering wheel changes, no throttle impairment. The car velocity did not change, and there was no obvious seizures. But when there is an aura, the patient tried to stop the vehicle. But however, there was no collision or any change in the other aspects, but the patient actually stopped driving. The partial seizure, there was risk of a collision, and there is a crash, and there is a change in the steering wheel velocity and the throttle impairment. The steering wheel velocity and throttle impairment can result in off-veering and fall off from the particular lane. An absent seizure, there was a 3%, 50% chance of a collision or a crash. So in clinical practice, how can we assess? So there are 3 types of neurological disorders which can result in a difficulty in driving. One is a fixed neurological deficits. Second is the progressive neurological deficits, and third is a paroxysmal neurological deficits. Now seizures come under this paroxysmal category. Now the other conditions like Alzheimer's, Parkinson's disease can result in progressive deficits, which can at in some time of his lifetime, the patient can lose his ability to drive safely. Now, visual fixed deficits we can always make out anytime. Patient having a visual impairment, particularly in the fields or in the perception, higher order understanding of the visual stimulus, or a cognitive impairment, memory, executive functioning, difficulty in multitasking, and motor weakness. These things can be elicited at the bedside. And paroxysmal disease, we have to get the history about syncope and excessive daytime sleepiness or hypoglycemia, or seizures like that. Now, in the Western countries, they have the European Union for regulation is slightly more for the patients who are willing to get a license. They have invited the group 1 license for self-driving, driving cars, motorcycles or mopeds, and group 2 for commercial or multiple large goods license. Now, the clinical situation wherein epilepsy in European Union, they allow to drive, they give a proper driving license within 1 year of fit-free period of seizures. And a provoked epilepsy seizure, the decision to drive or not is on individual basis, depending upon what caused or provoked the seizure. Whether that provocating factor is a recurrent factor, based on that, the neurologist can decide whether this patient is eligible to have a driving license. And a single unprovoked seizure, observation period of 6 months is enough. If there is no recurrence, he still can drive. Other loss of consciousness, again, the decision is with the doctor, the neurophysician. And the seizures which are exclusively occurring in sleep. Now, this pattern, if it is established for a period, then this patient can be fit to drive in the daytime. And a seizure without, we know that there are seizures without, which will not have an influence on the consciousness or the ability to react. So these patients, if there is a fixed pattern, they still can drive after a seizure-free period. Now, seizures which are occurring after a period of reduction in anti-epileptic dosage, an observation period of 6 months is enough. So we see that there is a balance between the community safety and the individual autonomy. At which stage are we going to give or allow the patient to drive? So in Western countries, it is more for individual autonomy. As I will be telling you in the next few slides, in our country, it is more for community safety. We are skewed towards the left. We are a little bit more, the law here is more strict, and it is more for community safety rather than for individual autonomy. So the current Indian situation is that according to the Motor Vehicle Act in 1939, which is very old, the application come declaration of physical fitness, there is a column called epilepsy. A single seizure of is enough to deny a license for the entire life. Now, this is very, very extensively very strict, 2 stringent criteria This was challenged by the Indian Epilepsy Association in 2005 because there are more epileptic citizens, better understanding of seizures right now we have, and better controlled by anti-epileptic drugs. In fact, there are other medical conditions with greater risk for accidents or which are actually allowed. Like for example, hypoglycemia, diabetes. As I told you in the relative risk chart at the early slide, there are other conditions like psychiatric conditions, diabetes, renal conditions which have almost similar or even more relative risk for road traffic accidents, but they are actually allowed. So one has to balance the safety of community and individual autonomy. And this can be done by reducing the knowledge gap and better reporting of road traffic events which are happening in the current state. So the Ministry of Surface Transport in 2005 has taken up this request by the Indian Epileptic Association to, but it has not come out as a final law, but they are considering it as people who have suffered from epilepsy attack and were free for 2 years, having a normal EEG and a normal MRI, can be allowed to drive in India, but it has not come out as a regular order. So in this talk, I have learned so much about, I like to thank Professor Pani for giving me this opportunity. In fact, yesterday I saw a case. This patient is a 50-year-old male. He had an accident just 3 days ago, a two-wheeler accident. There was no collision. The history he gave is that he just had a sudden brake and then and the bike skid. He had a blunt injury to the abdomen and had a mesenteric hematoma resulting in a jejunal resection. And the past history he had a recent MI and was put on dual antiplatelets. And there was a recent stroke probably related to COVID last year and developed a seizure following that stroke, and he had quit AED. And he was brought to the ER in LOC. And what was the condition? How at the time of the event of road traffic accident, whether he had a seizure, nobody knows. But the fact is he was brought in unconscious state. The duty doctor was looking into the emergency at that time, intelligently found that he didn't have any head injury following the road traffic accidents. It was more of an abdominal injury resulting in a mesenteric hematoma. But he didn't understand why this patient was prolonged in unconsciousness. So he suspected it is a post-ictal state and did a CT scan, which has picked up an old fog with a gliosis in the occipital area. So we know that this could probably result in his driving significant impairment in his driving abilities because of lack of proper visual analysis in this occipital area. And also there's a probability of a post-stroke seizure happening at the time of the accident. But all these data we do not have. As I said, there is a huge knowledge gap. Even in this hospital where I'm working, nobody has properly documented or the events happening around the accident. We do not know whether he had a real seizure. But the thing is, preoperatively on the table, he developed a seizure. So that was treated with anticonvulsants. Now our job is to inform him that he probably had a seizure resulting in a road traffic accident, and then strictly advise him not to drive anymore in his life. So eliciting a driving history and discussion, a small discussion about driving problems can be life-saving and this can lead on to better understanding of epilepsy and as better committed, socially responsible physicians. So